Hi, welcome back to NurseEdScholar. So we are on episode 4 of the Stop Fearing Drug Calculation series. I want you to know that my goal is to kind of break drug calculations down to, kind of digestible portions. So you can you can really understand what you're doing. And the reason why I'm saying that is because, students lose points on exams because of drug calculations. And, but you really need to know how to solve a calculation because, you really have people's lives in your hands. And so that's why I'm kind of taking this slow step by step. Soon I will be talking about drip factor and, how to program your IV pump and things of that nature. But this is number 4 of the series of 10. And so today we are moving on to injectable medication calculations. So your IM medicines, intramuscular, your sub-Q, and your IV medications. So, in this lesson, um, I want you to know that when you're talking about injectable medicines, these are more serious. Not saying that tablets or liquids are not, but injectable medicines actually work faster than your oral medicines. And some, injectable medicines are extremely, can be extremely dangerous, and they are high alert medicines. So basically, that just means that if you give them incorrectly, the patient can experience serious harm. And so today, like always, we're not really learning math, okay? We're learning how to calculate the medicines and then assess your patient. Verify should you give give the medicine to the patient, right? And because, the overall goal is really patient safety. So let's begin. So I want to start off with this slide because basically, what is an injectable medicine, right? So injectable medicines can be given by different routes. You have your sub-Q, your subcutaneous. You have your IM, your intramuscular, and you have your IV, which is your intravenous. And the route really matters because it affects how fast the medicine works, where the medicine is absorbed in the body, what needle or syringe would you be doing to, using to administer this medication? What safety checks are required? You know, um, do you want to administer all of the medicine? Okay, and when I'm saying that, I'm saying, do you need to call the provider to change the dose of the medicine? You know, um, literature states that safe injection guidance, it really, when you're giving injectable medications, you need to use aseptic technique. And really need to know how to safely use, needles, syringes, and those medication vials because you want to prevent contamination and patient harm. So with injectable medicines, there is a bit more risk with preparation and administering the medications. So when we're moving on to how do we actually, set up the calculation to perform the calculation for an injectable medicine, we're still using the same foundation, okay, which is good. You have the dose ordered divided by the dose available times the quantity. And for some of these medicines, it will be milliliters, and that will give you the amount to give. So, think about it again. The dose ordered is what the provider tells you what the patient needs. The dose available is what the dose is on the vial of medication. And your job, as the nurse will be to calculate how many milliliters to actually draw up on your patient. So when you're thinking about, setting it up, you're using dimensional analysis just like before. And it's helpful with injectable medications because the final answer will be in milliliters. And so, like I said, it's going to be dose ordered um, times the quantity available divided by the dose available. Now it's set up like this. I mean, you can put the ordered dose divided by the available dose and put the the quantity, which would be a milliliter, so it would be 1 milliliter on the side, or however the vial or the available dose, what milliliters is in that. So that quantity, when you're looking at milliliters, it could be 1 milliliter for the available dose. It could be 2 milliliters, as we're going to talk about when you reconstitute medications. Um, and or it could be, and you'll see it could be the available dose with a specific milliliters. And you'll see that as we keep going. Um, Also realize that as you're looking at the dimensional analysis, the milligrams cancel out and it will only leave the milliliters. Okay. And that's going to tell you that the calculation is set up correctly. So let's start. We're going to start with something simple, morphine. You have a patient. Your patient needs morphine 4 milligrams IV, push for severe pain. All right. And as you know, morphine is an opioid that's used for pain. So the order is 4 milligrams, but the hospital only has 10 milligrams per milliliter. Okay. So how would we solve for this? How would we set this up? And so you would set it up, the dose ordered divided by the dose available, multiplied by the milliliters that's associated with that available dose. So for this, it would be 4 milligrams divided by 10 milligrams multiplied by 1 milliliter. Remember, it was 10 milligrams per milliliter. So when you're looking at it, it's 4 milligrams divided by 10 milligrams. The milligrams cancel out times 1 milliliter, and that will give you 0.4 milliliters. So the nurse will draw up 0.4 milliliters. And so when we're using medicines like morphine, before you really give morphine, you really have to assess certain things. You're going to have to assess the person's respiratory rate because, my goodness, if their respiratory rate is 8, you're not going to give them an opioid because what do? They will depress respirations, right? You're going to look at the oxygen saturation, make sure that they are oxygenated well. What's their blood pressure? Is their blood pressure, can it handle the dose of morphine because morphine can lower the blood pressure as well. What's their pain level? Because you want to know what their pain level is before you give the medicine, because you're definitely going to evaluate the pain after the medicine. You have to chart that. What's their sedation level? If the person is lethargic, you're really not going to give them pain medicine. So you have to look at all of these. Do they have an allergy to the medicine? And when was their last dose of morphine? When did they last receive that opioid? Remember, morphine can depress the central nervous system, the respiratory drive, and that's why the patient's breathing must be assessed before and after. Okay? Because, and then also when you're talking about level of consciousness, like I said, if that person is difficult to arouse and they have a very low respiratory rate, their blood pressure is low, their vital signs are unstable, we're going to hold the medicine, okay, and notify the provider. Now, a lot of the times you'll see that medications, especially opioids, are given as needed. The patient has to request for the medicine. So, typically if the person is not alert or they're difficult to arouse, they're probably not going to ask for the medicine anyway. But these are still things that you want to assess on your patient because your patient may be alert, but they're really weak, and you're like, do I really want to give this medicine? Okay. And that's what being safe is all about. Let's move on to another medication. So we have ceftriaxone. It is an antibiotic, it's a cephalosporin. Um, and so the provider orders ceftriaxone 500 milligrams IM. And the available concentration is ceftriaxone 1 gram, reconstituted to 2.5 milliliters. Okay. So what are you going to do first? What would you do first? The first thing that you're going to have to do is convert the gram to the milligrams before you set up your dimensional analysis. Okay, so once you know 1 gram equals 1,000 milligrams, now you can move on. So you are going to divide the dose ordered by the dose available, which is 1,000 milligrams, And you're going to multiply that by 2.5 milliliters because that 1,000 milligram dose is associated with that 2.5 milliliters. So that's where that 2.5 came from that reconstitution. And so when you solve that, you will get 1.25 milliliters for your IM injection. And so you're giving ceftriaxone, before you give it, what are you going to be looking for as the nurse? You got to know their allergy history. You know, have they had a reaction to ceftriaxone or penicillin? Because, you know, cephalosporins and penicillins are cousins, okay? And for some people, they have a cross sensitivity. So if they're allergic to a penicillin, they may also be allergic to a cephalosporin. So you really want to ask the patient's history and if they had any previous reactions to any of these medicines so you can be on alert. Before you give ceftriaxone, you want to see if there are any signs of infection. If a culture is ordered, so if you're giving this for whatever reason, did they do a culture to make sure that this medicine, because you don't want to give an antibiotic before you do the culture. You want to make sure you grab that culture, then you start the antibiotic regimen that is usually associated with a particular bacteria. And then once that culture comes back, then you'll know, oh, yes, ceftriaxone will actually uh, eradicate whatever bacteria. Okay. And with this question, you had to reconstitute. So when you're in the clinical setting, typically what happens is that you'll have a vial and the vial will be of powder, and then you're reconstituting it with whatever solution is associated, with that medication. And so you're going to have to really read and really use your drug guide. So going back to your clinical judgment, if you have a patient that has a documented severe allergy, to ceftriaxone, to cephalosporins, you're definitely going to hold the medicine and notify the provider. Realize that the calculation can be right? It can be right, but if the patient has an allergy to the medicine, you don't do it. I mean, you would say, "Oh, that's just simple," but on testing and you're reading and you're seeing all of this stuff, sometimes that escapes you. Okay, so just sit back and read and say, "Okay, what is the question asking me to do?" Let's move on. Okay, here's another common medicine that you're going to see in your clinical practice, furosemide. That is a diuretic. You have a patient, and what is ordered is 40 milligrams of furosemide IV, and what's available in your facility is 10 milligrams per milliliter. So you're going to be solving for the milliliters. And so when you set up your dimensional analysis, you're going to have what is ordered in your numerator, 40 milligrams, divided by what's available, 10 milligrams, by the milliliter, which will be 1 milliliter per 10 milligrams of what you have available. And when you calculate that out, it's going to give you 4 milliliters. So the nurse is going to administer 4 milliliters of furosemide IV. So let's look at a clinical judgment piece. Now, when you're on the floor, before you want to give furosemide, remember it is a diuretic, a loop diuretic. And so you're going to want to assess a few things. You want to assess a person's blood pressure. You're going to look at their labs. We always talk about labs. So this is one reason why you really want to look at labs. You want to look at this potassium level if you're giving furosemide. You want to look at their kidney function. Um, urine output, lung sounds. Do they have any edema? Do you want to look at, what's their daily weight? Because furosemide will pull fluid off of you. And so you want to assess the patient before you give the medicine. What do you hear, see, feel, right, on your assessment? What do the labs look like? And then after you administer the medicine, you start noticing that urine output increasing. Do you notice the lung sounds changing? Do you notice the edema on the patient changing? Do you notice the weight change? Because you're going to have to reevaluate, reassess, and evaluate. That's how you're going to know the medicine is working. So, like I said before, furosemide is a loop diuretic. It helps remove excess fluid, and this can improve breathing, especially if you're fluid overloaded. You have heart failure, you have crackles, and your patient has crackles in their lungs. But also, it can lower the blood pressure and your potassium level. So, if your patient is hypotensive, if they're dehydrated, if they have a low potassium, you cannot give this medicine. You're going to have to hold it and notify your provider and be anticipating orders, from the provider. Okay. Another medicine that you're going to see that you're going to have to perform some kind of dimensional analysis on is ketorolac. Okay. So ketorolac is used for pain and discomfort. Um, so your patient has an order for 15 milligrams of ketorolac IV, and your institution has available 30 milligrams per milliliter. Okay. So how do you solve for the milliliters? Well, for this patient, just like before, 15 milligrams was ordered, 30 milligrams is what was available per 1 milliliter. So you are going to divide 15 milligrams by 30 milliliters, and you're going to, I mean, milligrams, I'm sorry, 15 milligrams divided by 30 milligrams multiplied by 1 milliliter. And so that's going to give you zero point 0.5 milliliters, and that is how much ketorolac you are going to give your patient. Now, ketorolac is an NSAID. So before you give it, you're going to have to assess a few things on your patient. Looking at those labs, how are their kidney function? Do they have a bleeding risk? Do they have a history of ulcers? Do they have an allergy to NSAIDs or aspirin? Um, are they using any anticoagulants? Or are they post-op? Do they have any bleeding risk post-op? Like I said, ketorolac is an NSAID. It does reduce pain and inflammation, but it can increase bleeding risk. It can affect a patient's kidney function. So you have to look at the labs. Does this person have renal impairment? Do they have active bleeding? Are they high risk for bleeding? Because if so, you're going to have to hold the medicine and you're going to have to contact the provider. Okay? Because you don't want to give stuff. We talked about giving things blindly. All right? Let's move on. Okay, we have enoxaparin. Okay. You're going to see that a lot, especially if you're working on a surgery floor or, ortho floor, the provider ordered enoxaparin, 40 milligrams. Oh, I am so sorry on this. I have IV. It's supposed to be sub-Q. That is my mistake. Let me see if I can. Oops. What is this? Not this. Not this. This. Uh-oh. Oh. Okay, I'm sorry, y'all. I'm trying to fix this as we speak. I don't know what I'm doing here. All righty. So enoxaparin is supposed to be given sub-Q. So the doctor ordered, I'm sorry, enoxaparin 40 milligrams subcutaneous daily. And what they have available is enoxaparin 40 milligrams in a zero point 0.4 milliliter pre-filled syringe. That is what you are going to see in the hospital. So let's look at the calculation. Well, with enoxaparin, which is one of the good things, is typically in the hospital, the dose is what's in the prefilled syringe. So if you have a 40 milligram dose, it's typically in a zero point 0.4 milliliter prefilled syringe. So the good thing is that when you use enoxaparin, you don't really have to worry about too much calculation. And so you're going to use that prefilled syringe and you are going to administer that zero point 0.4 milliliters subcutaneously. Now, when you're looking at enoxaparin, um, this is a pretty serious, medication, as you can see. You're going to have to check your platelet count. The patient has any bleeding, or do they have bruising? How is their renal function? Any anticoagulants? Have they had any procedures, right? Because enoxaparin, like I said earlier, you typically will see this on an ortho floor. It helps prevent and treat blood clot. Okay. But it also affects clotting. So you're going to have to worry about bleeding, right? So if a person is actively bleeding, maybe their platelets are low. Platelets, help kind of clot, they clump together to create a clot. So if their plates are already really low, you know, and the doctor has ordered this enoxaparin, you really want to hold it and you want to notify the doctor. You want to do an assessment of your patient. You want to say, hey, their labs are looking like this. Their platelet count is really low. Or would you still like me to give this medicine or would you like to adjust the dose? Because like I've said before in other videos, you are the eyes and the ears of the provider and you're the last safety step before getting, before the patient, if that makes sense. Okay, now we're entering some high alert medicine. Heparin is definitely one. When you're talking about high alerts, heparin and insulin are high alert medications because mistakes with these medicines can be life-threatening for your patient, causing serious, serious harm. So you're taking care of a patient in the hospital and the doctor orders 5,000 units of heparin subcutaneously. What is available in the hospital is 10,000 units per milliliter. Okay? We're solving for milliliters, right? So when you're looking at it, you will have what the doctor ordered, the 5,000 units in the numerator, divided by the 10,000 units in the denominator per or times 1 milliliter. So the units will cancel out. Okay? And so your final answer will be 0.5 milliliters of heparin. Now, before you give heparin, you want to assess for bleeding, bruising, platelet count. You want to see if PTT was ordered. Now, I tell students when they're like, which lab goes because you have PTINR and then you have PTT. But I usually tell students the two T's make an H kind of, but that's heparin, okay? And they typically remember that. You want to look at the hemoglobin hematocrit, make sure the person doesn't have an active bleed going on or what's their blood count. Are they on anticoagulants? Are they a fall risk? Okay. You want to know that because you're giving a medication that, it increases bleeding time. So, um, you know, it will, I don't know, a lot of people say thin the blood, but I guess basically what it is that it increases bleeding time. The blood doesn't clot fast. So if you have a person that falls and they hit their head, then, oh boy, they can have bleeding in the brain. And that is very, very important. So you want to assess, their fall risk. So if a person has an active bleed, dangerously low platelet counts, they can even have heparin-induced thrombocytopenia. You want to hold the medicine. You want to definitely notify the provider. You want to assess your patient, get some vital signs and everything, because you want to give a good report of the status of your patient at that time. Like I said, what did I say? Heparin helps prevent clot formation, but too much anticoagulation can cause life-threatening bleeding. So it is very important for you to monitor the patient's labs, make sure that you're giving the correct dose of heparin. Insulin. Insulin is a little different. We've been talking about milliliters the entire time. Insulin is different because it is ordered in units. Okay. Nurses will use insulin syringe. Typically, it should have an orange cap or an insulin pen designed for units. You do not want to mix up insulin units with milliliters. You know, a lot of students, and I want you to know this, the only thing that can be given in an insulin syringe is insulin. And the only syringe that you will use for insulin is an insulin syringe. I mean, that's it, because an insulin syringe is designed for units. All right, so the provider ordered 6 units of regular insulin, and the insulin available is regular insulin U100. So what does U100 mean? Well, U100 means that there are 100 units in 1 milliliter, okay? But in clinical practice, we will draw up the amount of units on that insulin syringe. So for this patient, you will draw up 6 units of insulin in your insulin syringe. Now, what are we going to do before we give insulin? Definitely assess that blood sugar. You give insulin and the patient's blood sugar is already 90, well, you're going to have a problem because you're going to lower that blood sugar. You want to see their meal status. When you're giving those fast acting insulins like Humalog, you want their meal right there, right? They about to eat, right? So you want to see what's their meal status. The type of insulin is going to depend on when you're going to give it, the time, insulin dosing time. Do they already have signs of hypoglycemia? You're going to check a potassium level if it's ordered. And if you're basing it off of a sliding scale, you want to, look and verify that sliding scale that you're going to give, because it's going to tell you how much insulin to give based on the blood sugar. Realize, and I know, you'll know this if you don't know it already, insulin lowers the blood glucose by removing the glucose from the bloodstream into the cells. So if someone gets too much insulin and the patient doesn't eat, the blood sugar can fall dangerously low because it's pulling all of the sugar out of the bloodstream and putting it into the cells. So if that happens, you want to, if you're like, wait a minute, you ordered, there is a schedule, for you to give this insulin, but you're looking at the patient's blood sugar. They're not eating. They may be even nauseated. So they're not eating. Um, their blood sugar is already low. Let's just say it's 90, 95. You're going to call the provider and say, hey, this is what's going on with my patient. I'm going to hold this medicine. Okay. You can always, I think I said this a while back, you can always hold and give later, but you can't give and take back. All right. So it's always good to hold, notify, and then, if the orders are changed, then move on from that point. So before you want to give an injectable medicine, always you want to make sure it's the right person, the right medication, the right dose, the right route, the right time. You documented it correctly. You're giving it for the right reason. Did the patient actually, when you evaluate them, did it give the right response? And I say that, because the right response. If you gave a medicine and you were anticipating, let's just say insulin, the blood sugar to go down a little bit, right? But you go and reassess and the blood sugar is all well, even before you check the blood sugar, you find that the patient's mental status changed. And you're like, oh, and you take you get a blood, you take a blood glucose and you're finding this person is like in the 40s, right? Well, that definitely wasn't the response you were looking for. So that's why you're going through all of these steps to make sure that you are doing everything possible to keep your patient safe. That's why it's important to reevaluate after you perform an intervention. Before you give any injectable medicines, you definitely want to check the allergies, labs associated, vital signs, compatibility of IV. One thing that you're going to learn is that certain medicines you can't give them together because it'll perform it'll produce a precipitate. So like if you mix two medicines together, it'll get cloudy. And you're like, that wasn't supposed to happen, right? Um, you know, um, You're going to make sure that the medicines aren't expired and so forth. One thing that I haven't talked about, and I'm really not going to spend too much time, is that you should know that you only use a needle or a syringe one time. You know, because you want to prevent contamination. So hopefully you know that already. Okay, let's keep going with some dosage calculations. All right, now we're moving on to cefazolin. Um, it's reconstitution. Um, you have the provider, I'm sorry, ordered 750 milligrams intramuscular, but all that's available is 1 gram. So cefazolin 1 gram vial. So after you reconstitute it, whatever solution, you have that powder, the concentration now is 1 gram per 2 milliliters. Okay. So what do we do first? We are going to convert that 1 gram into 1,000 milligrams. All righty. So after the conversion, it was 1 gram per 2 milliliters. You're going to change that 1 gram to 1,000, and now it's 1,000 milligram per 2 milliliters. So you're going to take what is ordered, that's 750, divided by that 1,000, the milligrams cross out, and then you're going to multiply that by 2 milliliters. And that is going to give you 1.5 milliliters IM. And before you give cefazolin, same things. Assess, allergy history. What's the infection status? Did they have a culture? You're going to find that on any antibiotic. Okay. Did they obtain a culture? Um, and did I reconstitute the vowel correctly? Okay. Um, one thing that you want to know is that if you mix things incorrectly, the concentration, if you're like, oh my goodness, it's unclear, how do I reconstitute this? They typically have pretty good instructions and the unit that you're going to work on. Sometimes they even have cheat sheets on the wall. But if the label doesn't match the order, if you mix it incorrectly, of course, you do not administer. You call the pharmacy and say, hey, this doesn't seem right. Can you send me another one? Okay. All right. So let's do an unfolding case study. So you have Miss Lewis. She's 76 years old. She was admitted into the hospital with heart failure exacerbation. She's short of breath. She has crackles and in both her lungs. So they're saying that the bases of her lungs. She's got 2+ lower extremity edema. And the doctor orders 40 milligrams of IV furosemide. Okay. And what you have available is 10 milligrams per milliliter. Okay. You go on and you assess your patient. And during that assessment, the blood pressure is 88/54. Their heart rate is 104. The potassium is 3.0. They're on 2 liters of O2. They're at 90%. And their urine output is 20 milliliters an hour. And if you can remember, it's supposed to be 30, right? Hmm. Okay. Right. So what are you thinking? All right. So the patient has an exacerbation of their heart failure. You've listened, you've auscultated those lungs, they have crackles. She has 2+ edema. Her O2 sat is low, the blood pressure is low, the potassium is low, the urine output is low, you know. So you're like, I got that. And then you're like, okay, let me calculate this dose. So the 40 milligrams, which is ordered, by the 10 milligrams you have available per milliliter. And so you're going to give 4 milliliters, right? Hmm. So before you got to think of Miss Lewis, right? So you ask yourself, did I calculate this right? Yeah, 4 milliliters. That's what I need to give her, right? But is the patient stable? They're hypotensive, they're tachycardic, you know, you need to think about it, right? You know that furosemide removes excess fluid. It helps improve breathing, but this patient is hypotensive. The potassium is low. If you give the furosemide, you're going to make it worse. So what do you do? Well, you're going to hold it. You're going to notify. You're going to monitor your patient. You're going to anticipate new orders because this patient is hypotensive and has hypokalemia. Like we said, furosemide can lower the blood pressure and the potassium level. As you know, they're already low. And if you give it, oh boy, you're going to put the Miss Lewis at risk for dysrhythmias, weakness, further instability, and you have a problem on your hands, right? So you're going to hold the medicine. Okay, so you held it, right? And you notified the provider. And so, you're going to learn as a nurse, what am I going to anticipate the physician to order? So they may say, okay, well, we need to give some potassium replacements. Her potassium was 3.0, so it's low. So you're anticipating, oh, I'm gonna have to give a K rider. Maybe. You're gonna say, well, maybe they want to repeat the labs. Maybe they want to modify the diuretic. I'm going to have to increase my monitoring of the patient. What about their O2 sat? It was low at 90%. You're going to anticipate the provider coming down. Oh, well, I'm coming down. I'm coming down to see Miss Lewis. So as a nurse, you are going to anticipate orders and get ready Because when they come down, you want to say, you may not open up anything, but you're going to say, okay, I have this, I have this, I have that. So you can work on your patient pretty quickly. All right. So when we're talking about injectable medicines, there are some mistakes. The mistakes are usually the same. Students confuse units and milliliters. Heparin is in units, but the final amount may be in milliliters. Students forget to convert grams to milligrams. You want to make sure that the units match when you're calculating. They may not pay attention to the concentration. The injectable vials that you use come in different concentrations, so you really have to look and say, okay, do I have the right concentration? Um, One thing, I think I talked about on another video, if the amount, the volume, the milliliters of what you're giving your patient seems unusually like a large quantity, for the route that you're giving it, stop and verify. If you normally, I'm just saying, um, let's just say heparin. If you're normally given 0.5 milliliters of heparin, and for some reason it says 10, and you're like, I've never given 10 milliliters of heparin, right? You got to stop. Something's wrong, right? Or, students just totally just skip clinical judgment, just like we were talking about. Their math may be right, but giving the medicine is still unsafe. Or their math is wrong, and they're like, well, I'm still give it. It seems silly, but that happens a lot, especially when you're nervous and you're rushing, and then you skip assessments. You don't assess your patient before you give the medicine. You don't realize that, man, I didn't realize Miss Lewis's blood pressure was so low, and here I go, I give furosemide, and then I made her worse, and now we're calling, a rapid response, and you have all these problems. Okay, and these are common things that student and new nurses make. Okay, we're close to the end. I'm glad you're hanging in there. So we have some rapid questions. I obviously do not have the answers on here because I want you to try to figure them out. So, the patient gives ondansetron, and that's for, you can use it for nausea. 4 milligrams is ordered to give IV, and what's available is 2 milligrams per milliliter. Remember ondansetron, it helps with nausea, vomiting. Well, you want to assess nausea and vomiting because it does help with nausea and vomiting. Um, um, but you want to assess for allergies. And ondansetron is one of those that will lengthen the QT interval, so it can be dangerous for cardiac patients. So, but ondansetron, I think that, yeah, that's right. That's right. So let's see. Okay, so you set up the problem, and so your answer should be, all righty, 2 milliliters. Okay, that's what it should be. All right. Second one, hydromorphone. That's an opioid. So you have hydromorphone, 0.5 milligrams IV ordered, and it comes in 1 milligram per milliliter. What would the answer be? Realize that, hydromorphone, like I said, is an opioid. So of course you're going to assess your respiratory rate, the sedation level of the patient, the pain level of the patient. Do they have an opioid tolerance? Um, and what's their blood pressure? Okay, so set up the problem, um, and let's see what your answer is. And I'm gonna put it right here. Okay, hopefully you got this. All righty, 0.5 milliliters. Okay, good. Let's move on to another. Methylprednisolone, um, that, um, oh my goodness, I can't, forgot. I know what it is. It's a steroid. Oh my goodness. So the doctor ordered 40 milligrams IV, and what you have available is 125 milligrams per 2 milliliters. So let's set it up and see what your answer is. Remember, when you have a steroid, you have to check for blood sugar because it can raise your blood sugar levels. You look at infection risk. Steroids tend to reduce the inflammatory response. So you want to see if they are at infection risk. Look at their immune status and why are they getting steroids. Okay. So hopefully we had enough time. So this would be your answer. That's, you can see that. All righty. 0.64 milliliters. So that is how much you are going to give IV. All right, so we have a quick heparin sub-Q question. I think we've done this one already today. Um, you have 5,000 units ordered. You have 10,000 units per milliliter available. And what would that answer be? All righty. So that's that zero point 0.5 milliliters. And remember with heparin, you want to assess for bleeding, platelet count, bruising, fall risk, and anticoagulant history. All righty. So today we learned a lot of stuff. A little dimensional analysis. We kind of went over canceling those units, verifying the concentrations, assessing your patient. And that's why it's so important to assess your patient, their labs, and looking at is it safe to give a medicine right now? Because sometimes it's not. So thank you for hanging with me. Um, if this video helped, you kind of understand injectable medications, kind of made it a little easier. Please like this video. Please subscribe to Nurse Ed Scholar. Share it with your classmates that are struggling with medication math, and then kind of putting together what medicines are used for, what are you supposed to assess for, okay? And answer this question, like what injectable medication calculation is hardest for you? Is it IM, sub-Q, IV, insulin, heparin? Um, in the next lesson, I'm moving on. Things are getting a little harder. We're going to do weight-based dose medications. Okay, you're going to see those if you're taking care of pediatrics, so children, critical care units, high risk medications. And then I think after this one, we're going to do some. Eventually, we're coming to IV flow rates. I'm going to do IV pump rates, um, infusions, so we're starting to get to the harder stuff, okay? But I want you to remember that dosage calculations are not just math. They are patient safety. And please remember that. So until next time, happy studying from Nurse Ed Scholar.